I'm going to talk a little bit about blocked tear ducts in children, because blocked tear ducts are very common and they're usually not a very serious condition, but it can be very frustrating and annoying for both the child and the parents. So a blocked tear duct, otherwise known as nasolacrimal duct obstruction or tear duct obstruction, is very, very common. And in fact, it can affect up to 5% of children in their first few months. However, what is reassuring is that of those 5% of children, the vast majority will actually get better over the first 12 to 18 months of their life without having any extensive medical intervention. Well, what we do is, with a careful history taking, you will find that the child will have a sticky eye, often mucus and discharge in the inside corner of the eye, particularly in the mornings, or the eyelids are stuck together. There is very rarely any lid swelling, but one of the key signs that we look for is the absence of any redness of the eye, because the redness of the eye tells us that it's a blocked tear duct rather than a conjunctivitis, which can be an infection or an irritation or trauma to the eye. So a blocked tear duct, the white part of the eye will usually be white. So there are other signs that we look for on examination, of course, and that would include looking for swellings around the lids or nodules around the lids, or a swollen tear duct at the inner corner by the nose. But usually we would then, and then we would progress to checking the vision and the eye movements, because it's important that the eyes move well. It's important that the child has clear vision. And then after that, we would explain to the parents and draw some diagrams and illustrate what is going on with the blocked tear duct. So treatments can include observation and some simple treatments, which I'll talk about. But in some children, a small number will have to go on and have the tear duct probed and examined under general anesthetic, which is a diagnostic procedure as well as helping the treatment. And so going back to the non-surgical treatments, one of the things that we do is to encourage regular cleaning of the surface of the eye, but not too frequently, perhaps twice a day, with water that has been taken from a kettle that is cooled down, or sterile saline, and this is wiped on the inside corner of the eye twice a day. Another measure is to protect the skin of the eyelids from becoming sore with the extra tears and the mucus and the discharge by using a barrier cream. And this can be a simple moisturizer such as E45, or it might even be a skin cream, or it can be something as simple as some olive oil applied to the skin a couple of times a day. And this will prevent drying and crusty skin, which can cause an irritation to the eyelid. It is important that antibiotics are not used. Antibiotics do not have a place in simple tear duct blockage. They do have a place, and they are used in the presence of an infection. But infections with tear duct blockage are very rare and can be easily diagnosed by an ophthalmologist, a pediatric ophthalmologist, and someone such as myself who deals with children with blocked tear ducts frequently. Signs of an infection, which again I emphasize are very rare, would include the eyelid being completely closed, being very red on the inside corner, and sometimes a hard swelling or lump at the inside corner as you approach the nose bridge. And this condition is called a dacryocystitis. So it's an infection of the tear duct, and it is one of the rare reasons for having antibiotics, and it is one of the rare reasons for needing to go to operating theatre in a small child or baby to have it unblocked, which is something I only have to do once or twice a year. So returning to the vast majority of children who have simple tear duct blockage, if they don't respond over a period of time, in other words, if they get to the age of about 10 to 12 months, and we find that the tear duct blockage symptoms continue with continued watering, and continued stickiness, then the parents are offered a short procedure under a general anesthetic as a day case procedure in hospital. And this requires, under anesthetic, the tear duct is examined, a probe is inserted to clean out the tear duct. This is rather like a small pipe cleaner, cleaning out the delicate tear duct as it goes from the inside corner of the eyelid down into the nose. And at the same time, the bottom end, the drainage end, is looked at inside the nose with a nasal endoscope to see if we can identify the area of blockage. That sort of procedure takes about half an hour. The child would go home 2 to 3 hours after surgery, and the recovery period would be very brief. Within 48 hours, they would be ready to return to nursery or any other activities if they were going back to school. So in the first half, I talked about the indications for surgery. So surgery would initially be required for persistent symptoms in a child who's reached the age of 10 or 11 months, and between 10 and 11 months and up to 2 years old, a probing of the tear duct with a nasal exam and endonasal examination at the same time would be the procedure of choice. At the same time as doing this first procedure, I will sometimes insert a stent, which is a soft tube made of silicone, and that can go in the tear duct and it holds it open. The stent can usually be removed in the outpatient clinic 1 to 2 months after surgery, although in some children, they do have to return for a short anesthetic to have the stent out. Whilst the stent is in, it's completely painless. You're not aware of it, you can't see it. And in fact, a small percentage of stents will fall out spontaneously anyway, which can actually be helpful. So if the first procedure doesn't work to unblock the tear duct, then in a very small number of children, less than 1% of children, they may require a formal drainage operation at the age of 4 or 5 onwards. This is called a dacryocystorhinostomy, or the shorter word is a DCR, dacryocystorhinostomy. This involves a 1 to 2 hour general anesthetic, and an incision is made through the skin of the nose bridge to access the tear duct by removing some bone, and then joining the tear duct artificially by joining the tear duct, the tear sac, to the inside of the nose, thereby diverting the tears so that they flow freely from the surface of the eye, and you are then free of the symptoms of a watery eye and stickiness. But again, the DCR is a major procedure. It's done on a very small number of children, not until the age of 4 years old typically, although it can be done younger, and the recovery period is longer. They would need a week off after surgery and before returning to nursery or school. During the DCR, I mentioned some of that. A small incision is made on this under general anesthetic. A small incision is made on the side of the nose bridge. This incision is about 10 millimeters, and eventually, after months after surgery, will fade away to just produce a small line and a visible scar. But through that incision, one accesses the bone of the nose. An artificial channel is created by going through removing some of the bone in that area, and you join the tear duct to the inside of the nose. You then close the area again and replace the muscle and stitch up the skin, and the child goes home with a silicone stent inserted from the inside corner of the eye all the way down into the nose. That stent can be removed in the outpatient clinic 1 month or so after surgery. The tear duct probing surgery and unblocking the tear duct is not a very painful procedure, and although one has to work through the bone to unblock it, no bone is removed with a simple tear duct procedure. So there might be a bit of mucus in the eye. There can be a couple of drops of blood from the nose, but generally simple painkillers are needed. Some are given during the anesthetic, and then afterwards a simple painkiller like Calpol might be needed for 24 hours, 48 hours, but the child will be back to their normal self within 72 hours after surgery. The recovery period after the blocked tear duct surgery is very quick. Within 72 hours, the child will be back to normal behavior. They might have to put some eye drops in for a week after surgery, just to prevent any infection and to settle down the inflammation. The recovery period after a DCR, the dacryocysto rhinostomy, can, as I said earlier, be a little bit longer and can take up to a week off. A week would be required off school, or a week would be required off nursery, while the swelling around the nose bridge settles down. And these, again, simple painkillers might be needed by mouth, such as Calpol. But most of the pain is in the first 24 hours.